1 minute past 12 there, Dominic. So I'll do the introductions and then we'll start. So colleagues, you're all very welcome to this webinar, eXRt for Rehab webinar. My name is Professor Joe McVeigh. I am Head of School of Clinical Therapy at UCC and a board member of the eXRt for Rehab Consortium. So I'm absolutely delighted to welcome and introduce Dr. Dominic Holmes, CEO and co-founder of eXRt. So Dr. Holmes, Dominic, is the CEO and co-founder of eXRt, this intelligent healthcare platform, and it's a startup company focusing on accessible rehabilitation for neurological disorders such as stroke. So Dominic holds a PhD in computer science. During his research, he spent a significant amount of time with healthcare professionals, looking at how immersive technologies can better engage patients in their rehabilitation and provide personalized and adaptive virtual reality physiotherapy. So eXRt was founded in 2019, and it was founded to commercialize its virtual reality physiotherapy platform. And the platform provides elements such as virtual physio appointments, advanced movement analyticals, video chats, and enables 24/7 access to physiotherapy. So we're really looking forward to hearing all about it. There is a Q&A function. So Dominic's going to speak for about 30 minutes or so. There's a Q&A function. Please use the Q&A function. If you put in some questions, I'll feed those back to Dominic at the end. And by all means, put up any questions you have. So Dominic, will I pass over to you now and I'll let you kick off.
Yeah, thank you very much, Joe, for that kind introduction. I was going to do a bit of a background about myself, but I think you've nailed it there, which is good. So I'll just get on. So as Joe says, my name's Dr. Dominic Holmes. Yeah, I studied computer science with games development. Went on to do a PhD in really focusing on upper limb movement modeling for really adaptive and personalized stroke rehabilitation, with a focus of using virtual reality to do that. And I think whether the stars aligned or not, I'm not sure. But at that time when I was doing my degree, my granny had a stroke, and where the PhD was just made for me, which is always always nice. I then decided, well, why I could use my skills to help people, and that's what I did. I'd done my PhD for 3.5 years. Then I became a research associate on the European project that I'll talk about later on. And then from the results from that, I co-founded eXRt Intelligent Healthcare with my co-founder, or my previous PhD supervisor, Professor Darrell Charles. So just what we'll talk really about today is where eXRt came from. It wasn't just a company formed in 2019. There was a lot of background, a lot of research behind it. I'll talk a little bit about the challenges that we're really trying to solve and the mission behind eXRt. And then we're going to do a little bit about the technology, what features, how it's used, and we'll talk more around the intelligent system as well. We'll talk about some of the research. Can't tell you all of the current research that's ongoing, but I'll share what I can, and we'll also talk a bit about our NHS involvement. And then, as Joe says, we can finish up with some questions afterwards. So, yeah, before I was even a student at Ulster University and studying my computing degree, there was a research team behind the development of this type of technology and how we could use gamification and virtual reality to motivate and engage patients in rehabilitation. Although the technology and the hardware, for example, wasn't really there, it was very heavy, clunky, and it wasn't really suited for everyday use for patients. The team were really focused on looking at how we could use AI to monitor patients' behaviours in their movements, monitor their progress, adapt the user interfaces, and use intelligent algorithms to detect specific exercises for stroke rehabilitation. And that was with the help of an interdisciplinary team that include physios, occupational therapists, computer scientists, and other healthcare staff. And as we started to build that research, I came along and done my PhD, like I've talked about, and at that time the hardware was now starting to catch up, and we were finding technology or the hardware itself was more usable, more portable, and just really fitted what we needed. So then in 2017, we stepped out and really pushed our research and more into the public space. And at that time, we competed for a 3-phase Horizon 2020 project called the Magic Glass or Magic Project, which is really focused around mobile assistance for groups or individuals in the community needing stroke rehabilitation. We were selected as one of the 3 companies to receive funding to conduct the product development, but also the clinical study that was involved. And our real focus was on the usability and acceptability of incorporating stroke rehabilitation into a virtual reality system, which we then called Magic Glass. And it was integrated into the community stage of the current stroke care pathway. And then with a few delays through COVID, we finally got the results in 21 that really validated the technology. And that's when we started to spin out eXRt Intelligent Healthcare as the best way that we thought possible to share this with stroke survivors. And at eXRt, what our real mission really is, and our staff are really motivated to do this, is that we believe that every patient deserves access to consistent, motivating, and outcome-driven rehabilitation and support, whether that's at home or in hospital or even in the community. We want to try and deliver that accessible rehab. So what challenges are we trying to solve? And some of these stats will probably be very familiar to some people in the audience, but I'll go over them anyway. So globally, there's 12.2 million people have stroke each year, and 93 of those people are living with the effects of stroke. In the UK, for example, 100,000 new strokes occur, and 1.4 million people are living with the effects of stroke as well. Now, the real problem that we're really trying to solve here is therapists are now asked to meet new guidelines since 2023 of 3 hours of motor function therapy per day, 5 days a week. This is up from the 45 minutes that they were asked to deliver. And you can, when talking to therapists, it seems near impossible for them to do that. And then when you couple that with NHS staff shortages, we're really creating a bottleneck where patients or therapists don't have the time to deliver the right rehab, and there's not enough staff to do it. And that means patients are going to suffer and not get the level of rehabilitation to see any neuroplasticity change in recovery. And I suppose one of the other issues that we're trying to solve, and I suppose one of the questions that we need to answer is why we chose to do upper limb rehabilitation first. What we've had, and before eXRt was even formed, this problem has always been going on, but the recent stats there show that 50% of patients still have an upper limb disability after 6 months in the chronic phase. And that's in contrast to 85% of stroke survivors are walking independently within 6 months. And really, the primary reason for that is that stroke patients, when they do go into hospital, they want to be able to walk again. And so a lot of the focus on the rehabilitation goes on to the patient needing to walk with that goal-driven rehabilitation. That's not to say they don't do upper limb rehabilitation in the hospital, but the stroke survivor really wants to focus on that. And then that adds an extra complication is when the patient does go home or goes into the community, then they're asked to live independently at home. For example, trying to make a cup of tea or brushing their teeth becomes a little bit more challenging because they haven't got the level of rehabilitation for their upper limbs. So part of our mission is to hopefully we can use our technology throughout the whole care pathway, including the patient's home, so that we can deliver that upper limb rehabilitation and make them more independent. So now we'll sort of get into a bit about the technology in these next few slides. So ReSync is what we call our virtual reality platform. It's I say, it's an upper limb rehabilitation platform that really encourages games. So we gamify the whole rehabilitation process, and these are all designed with OTs and occupational therapists. So we have a series of different games that do different exercises, and all that data are then around their hand movement, how much time they're using it is all then sent to the therapist, and I'll show you that in a moment. But some of the key results that we've come out from our research, and on the data of the platform, is we can provide 540% more repetition in less or the same time, which is around a 45-minute session. 65% of patients improve their upper limb activity in independence when it comes to the likes of grooming, whether that's brushing their teeth, for example. And then we've now exploring doubling the healthcare or the hospital's capacity to treat patients, where we could use 2 headsets with 1 therapist, so they can be treating 2 patients at the same time, which would be really beneficial for the healthcare systems. And now over our new algorithms for tracking movement, and in particular a lot of joint movement, we're hoping to provide a lot of measuring and assessments, so that therapists can see directly and far more quicker all the progress that the patient's making using the virtual reality system. So in terms of the virtuality, or what the patient sees, you can see there's a few of the games there that we have in our platform, and then from air hockey to cooking burgers at your local chip van. But some of the features that are in our ReSync virtual reality headsets are, we've tried to promote activities of daily living, training. All of our games encourage repetitive task training. You have the option to use constraint-induced movement therapy. We have a virtual mirror therapy mode as well that you can turn off and on for patients to have severe disability or no movement at all in their arms. They could be using that. Again, coordination. Air hockey is quite a good example of that, having that hand-eye coordination. And then some of our games will try to promote the scanning, encouraging the patient or the stroke survivor to look around, interact with certain objects in certain areas, so to promote that, or reduce that visual neglect, and help train them to look in certain areas where they can't see in a way. And then with the bilateral movements that you're probably seeing in some of the videos there now, with the clapping the hands or using the salt shaker to put salt on the burger, for example. And then a lot of our games currently, physical-based games, have degree of cognitive level. So you'll get games that are quite simple cognitively, games are a little bit more complicated, so that adds that little bit more variation. We're also coming out with some new games specifically for cognitive rehabilitation around memory loss, problem solving, for example. These are really about the reason why we're doing this is because we understand that if people have severe cognitive impairment, they're less likely to have or they're less likely to do or understand the physical rehabilitation games. So we want to try and also rehabilitate the cognitive side of the patient as well. So that's what the VR really is, and what features it has. But behind what you don't really see about through those games, behind the scenes, we're collecting quite a lot of data around usage, around the joint movements, where they're moving, weaknesses, certain areas, fatigue, for example. What we do then is we built a ReSync therapist web app, so the patients can then, or a therapist, sorry, can then view the patient's progress from having some idea of how many goals they met, to how much time they spent, how many reps they've done on a daily basis, and then all the joint and hand movements that we can show you shortly in the next few slides. So having that information, almost instantly in the therapist's hands, allows them to track the patient a wee bit more sooner and see whether they're improving or where they're declining, and take action a wee bit sooner. And one of the other benefits to our platform is the real-time video streaming service. So if your patient is at home or in the community and you can't get to them, for example, or if they're in the hospital and you want to see what they're seeing at the bedside, you can do a live video stream and see exactly what they see in the virtual reality. You can even talk to them and support them, and they can talk back to you. So it's like having a video chat feature for that, but it's pretty real beneficial in some of our users at the moment, around, especially in the community trusts that we're working with, where they can offer that remote rehab, especially in a lot of bigger areas that they cover that they can't actually get access to. And then part of that, the recent Therapist Web app is around building that rehabilitation program. With our algorithms that we've developed, we can now detect specific exercises for rehabilitation for stroke. So anything from gross movement with that shoulder movement right down to fine finger movement, such as finger flexion, that grasping with supinate, with a lot of exercises that can then be added to the games, and then they can play the games while doing that exercise, and that can all be tracked, monitored, and even adapted in real time to make it easier or more difficult for the patient. We have a lot of games that you can pick from, and most of our games have at least 2 exercises that can be used with it, so you have a fair bit of customization there, and then you can set the baseline difficulty. So that baseline difficulty sort of starts where, okay, this is where they should start at, and then the intelligent system behind Resync then takes over and adapts it to more granularly rather than easy, medium, difficult. It's more fine-tuned to make it more easier, and adapts that user interface to the patient. But I'll talk a little bit more of that in the next slide. So yeah, so in terms of the intelligent system, so we've done a lot of research before even eXRt was formed, around the adaptive user interface, and how we can make this system as personalized for the patient as possible, because we know that each individual stroke patient can be different. So we have, with our precise movement data that we capture, what we're able to devise what we call is a behavior movement profile. From that profile, we can identify where the patient is weakest at, what exercise they're not performing well in, what areas of the space that they're trying to play the game in they're neglecting, where they're good, where the performance is, where it's declining. Also signs of fatigue, and signs of boredom as well. Sometimes they can get bored. So we by knowing this information, then we can change the interface or change the games. But where that's making objects appear in certain areas, they encourage them to go in places that they're neglecting or they're ignoring, or make objects a little bit bigger to make it easier for them. And then identifying the likes of fatigue, we can make the game easier, to allow them to engage for longer, and not to fatigue as quick, so they can continue to engage in the rehabilitation for longer. And then as I mentioned earlier on, we have our exercise detection algorithms. We have, because of the traditional hand tracking that's in some of these VR headsets, it's very limited on number of exercise or gestures that they call them. There's not a lot of them, so what we've done is we've built our own, and we built that rich library of stroke-specific rehab exercises that I talked about there in the previous slide. And by doing that, what we can do now then is we can monitor as they do those exercises. We monitor those. We can adapt those and make those exercises more difficult to to achieve or more easier to achieve, and that allows for additional personalization. So if the patient can't, for example, if we can't pinch enough in the, then what we do is we adapt that and make that a wee bit easier or a wee bit more difficult depending on the performance. We have other intelligence behind our platform as well, but we just can't discuss those at the moment. Hopefully in future webinars we can. Yeah, so that's the real heart of our system around personalized and adaptive interfaces, and part of that came from my PhD. And then just to finalize the technology section, we're really proud to offer a brand new mobile app for the patient. And the real idea for that, and it really towards what our mission really is that accessible rehab, and being able to give them, as quick as possible, access to rehabilitation and support. So what we've done is we've built a mobile app for the patients who they can log in, they can see their performance in the virtual reality, they can self-manage their own rehab, they can get that feedback a lot sooner rather than having to wait for a therapist to come around. They can see the performance in their exercises, they can see how many goals they've met for this week, for example, as well as control the VR remotely, being able to log in themselves. It makes it so much easier, considering some of the research that we've conducted. We've learned quite a lot around the usability of the system. And then we're really proud to partner with Stroke Association, who have been working with us to create a lot of good support information for the stroke survivor, but also the carers, who can access this information in a more physio-friendly way. And just really the aim of that is to help stroke survivors and the carers find the right support and learn more about this life-changing condition and manage it better. And then they also have direct access to the support helpline from the Stroke Association. And this has now been rolled out in some of our trusts at the moment. I'm hoping to share this across the rest of our users. So then moving to the research. So before we essentially formed eXRt, we did the European trial that I talked about, at the very beginning there. And we recruited 111 stroke patients. And really it was to test, the aim of that was to look at the usability and acceptability of incorporating stroke rehab into virtual reality system. And we called it Magic Glass back then, integrate that into the community stage of the stroke care pathway. It was a multi-centre pre and post home-based intervention study that was conducted in Northern Ireland Health and Social Care Trusts and Italy. Each patient also received individual upper limb training program that focused on gross and fine motor skills, and they were given that system for 6 months. The results from that, we pull out some of the significant results. So we got a score of 84 on the system usability score, and this is really in that excellent category. It's shown that our system was really easy to use for patients. 65% needed less help with their grooming activities, which is fantastic considering we're upper limb rehab focused, and 37% improved their upper limb stroke specific quality of life, which is fantastic. And then following on from that, that research, eXRt then had conducted an independent health economics report. And one of the key benefits was that we were able to save healthcare organisations £4,000 per patient, which, when you consider the number of strokes that happen per year, is quite a significant saving. After our European project, at that time we went back and we took all the learnings from that, and we built a more portable, easy to use, more accessible system. And at that time we got in connection with Emma Dunn, who was very experienced OT and stroke rehabilitation at the Belfast and Health and Social Care Trust. She's over 25 years of experience. And really at that time when we met her, she was looking at how technology can meet those stroke guidelines that we talked about previously, which were quite challenging. And we worked together on a quality improvement project, to try and increase the number of repetitions of upper limb rehabilitation that will then hopefully show neuroplastic change. And what we've seen from that was between 200 and 500% increase in the number of repetitions using ReSync compared to conventional therapy, which was around 39 repetitions. Also, some other learnings from that was that we knew that this technology was really new, and but what we identified as patients, the first 1 to 2 sessions, they were really learning still and how to actually use the system. And after that, then they started to increase the number of repetitions. So with that, we can now understand that there's still a learning phase. The patients still need to understand what these brand new technologies are, and then we start to see benefits after that. Following on from that project, then we embarked on another quality improvement project with Emma, and the real aim for that was to look at what barriers there was from a staff perspective, a rehabilitation staff perspective. And our aim was to use using ReSync with the stroke occupational therapy team to evaluate acceptance and staff competency within the stroke care pathway. And what we did was we trained them up. The Emma and her colleague, who were the lead therapists, they trained their staff on the system, how to use it. They then let them use it with the patients, and then we had a 1-month follow-up after that. And the results then were we got a system usability score 81 score on that, which was considered excellent. So we knew that the system was really easy to use for staff. In terms of staff confidence and competency in the training, 67% of staff strongly agreed they would use the system frequently. 67 agreed or strongly agreed that they felt confident using the system. And 100% of staff demonstrated independent competency in both the VR headset and the web app. However, at the follow-up 1 month, we've seen the competency did vary, and you can see on the right-hand side there, the graphs. It did vary a little bit, but in the majority of the results still remained in the independent category, which is still promising, but we're still learning from it, which is we'll now move forward in a new research project that's funded by NIHR to look more in depth on the analysis of these results. In terms of safety, all 18 staff reported no safety concerns during the VR sessions, and there was no adverse events that happened with the patients. So really, overall, looking at both projects, we've seen a 200 to 500 increase in repetition, which really addresses the fundamental limitations of conventional rehabilitation, where typically they're only getting 39 repetitions. And that's compared to that 300 to 800 repetitions that are suggested for audible motor learning or that neuroplastic change. So we can see that ReSync is making now strides towards increasing the repetitions towards that neuroplastic change and those recommendations. In terms of staff, the score of 81 indicates that the system's highly usable for therapist staff, and the absence of adverse events from patients has also confirmed a good safety profile. However, we did see that decline in competency after 1 month follow-up, and that's helped us with a lot of learnings around training protocols, access to resources in different ways, and more continued access, more follow-up training that may be required, and hopefully we can develop a protocol around all that we can then provide more in-depth training, for example, to increase that competency for staff, and hopefully that will lead to more adoption and into routine care. So these next few slides, I just want to sort of go through a couple of sort of testimonials on, you know, what impact our ReSync system has had on patients, and also what other occupational therapists and clinical and physiotherapists have said about it. But really, this one for me, meeting Will, who was one of our first participants on the Horizon 20, the European project, really showing his impact. So he was a music teacher, a really good saxophone player before he had a stroke, and then he had no movement. Once he had a stroke, he had no movement in his left arm, and we met him to consent him onto the project, and he'll tell you his story through the video.
When I was 44, I had a stroke, a huge severe stroke. I was in hospital, and I could walk maybe 12 steps when I was discharged, but my left arm was totally paralyzed. Now, luckily, I had filling in it, but I didn't have any movement at all. Luckily, the OT from the local stroke team, community stroke team, recommended me to try the virtual reality trial from the University of Ulster. And I was the first person to try it in Portadown Health Centre. Tried it for maybe an hour and had fun playing the games. And the following Tuesday morning, I got my first arm movement in my left arm. So after 4 months of nothing, I got my first arm movement, which was incredible. And I'm sure that trying the virtual reality just connected some pathway from my brain to my arm. And
so you can see the impact it's had on Will, the fact that, you know, after just a few sessions, he was able to see some flicker of movement, which I think in more things gave him hope on, okay, this potentially we could recover some of my arm and I could use it. And you can see in some of the video there, after the trial, he was actually able to use his arm more. And then since the trial, he's formed a band. He's a saxo player now, and he's got 2 albums on Spotify. So it hasn't stopped him, which is fantastic to see. And really, what we strive for, and you know, at eXRt Intelligent Healthcare is, if we can rehabilitate and give somebody a wee bit extra hope of regaining that independence, it's fantastic for us. And then I just want to highlight some of the quotes from some of our users of the system as well, and then some of the key users that we're working with now. And we hope that some of the data that comes from them we can share in future webinars or future abstracts and publications. But we're really excited to see what comes of this in the future. And really, just finally, to a few thank yous to some of the companies on screen. They've really supported us to develop the technology, supported us, me as a researcher becoming CEO of a company, which is quite scary. Yeah, they've supported me and supported the company, and I just want to say thank you. And then just thank you to eXR for Rehab, for inviting me to do this webinar. I've had great fun, and I hope the audience members have taken some from it. And I'm happy for anyone to get in touch with me if they want to discuss this further, or you know, partnership, or move forward with something else. Be happy to chat with you. Thank you very much.
Thank you very much, Dominic. That was excellent. Really interesting presentation. And I think you touched on a lot of really important points that are so relevant for anybody that works in this area. The notion of blended care, tremendously important. The future of not only patients that have stroke, but anybody with any impairments after neurological conditions is about the use of technology, and there's a lot of overlap between the work that you're doing and some of the work that we're doing in the Scale Up for Rehab project, which is a big InterReg funded project looking at actually how we scale up technology in rehabilitation. So there's an awful lot of interesting points you make, and one of the most important points that I think is the point you make around implementation and the challenges of that, and how we and some of our colleagues online have raised the question, how do we ensure that the technology doesn't become more than just, well, that was really interesting when somebody came and showed it to me, but it becomes embedded in practice. How do we implement it? How do we make it? How do we build the confidence of the therapist to use it all day, and on a regular basis? But I have some questions here, and I'll stop speaking and I'll pass the audience. So I'd quickly go through some of the questions, if you don't mind, Dominic.
Yes, grand.
Do you want to stop sharing your screen there? And
Yeah.
people will be able to see your answers. Thank you very much. So our first question, which class of medical device does your application belong to? So thanks, Corinne.
Yeah, so right now it's approved for Class 1 medical device. Yeah, so it's a software as a medical device. At this stage, we use hardware that's commercially available, and the reason why we do that is because what Joseph's been talking about is scalability. We don't really want to build a hardware technology that's specifically to us, and they have to come to us for hardware, but they can buy it from Amazon, for example, and load it onto our app onto their system.
Okay, thanks very much for that. Our next question from Natasha. Can you talk a little bit more about measuring and tracking of joint movements? How accurate are the sensors? What kind of sensors are they? And are there any plans for more specific joint tracking, for example, at the shoulder or the elbow?
Yes, so a couple of questions there.
Yeah.
Well, I'll start.
But I think you do. Do you track the shoulder, or is it only hand and wrist?
Yeah, right now we can track the shoulder. We are working on developing that. We haven't released it because we still need to test the measuring side of things. But the sensors, for example, they're on the headset itself, so there's small cameras. Those cameras then, what we use is image processing, so we track all the joints in each finger, hand, wrist, for example, and we're able to then measure that through that. And we've worked on a number of research projects around the accuracy on that, and we're currently have just received new research funding now to advance that even further. So I can't talk about that, but in terms of accuracy, we are, in terms of, if anybody, most people probably know what the goniometer is, and within 5 degrees of movement is very good, and 10 degrees of movement is still good. So we're within that 5 degree of movement, which is good.
And you're looking at the elbow and shoulder.
Yeah, and we're looking at that as well.
Okay. Are there any other, and again, that Natasha's asked, are there any other common patient-reported outcome measures built into the app, such as numerical rating scales for pain or fatigue or whatever?
It hasn't been built into the app. We're using our unique algorithms to do that. That's actually quite a good point, that we want to be, one of the aspects of our future is around that assessments. So if one of those measures becomes most relevant, we would be really interested in incorporating that.
Okay, thanks for that. And Amy asks, she's interested in the specific methods of personalization or adaptation. What AI data-driven methods have you used? Maybe you can't tell us that. And what metrics influence the algorithm? It's maybe you could tell us, but you're going to have to kill us all afterwards. Is that?
Unfortunately, I can't. I was hoping to publish it as part of my PhD, but I was told not to. I wasn't allowed to. Okay. So that keeps the stage within sensitive because some of our stuff is trade secret.
Okay, I suspect.
Sorry.
I suspected that. Thanks very much. We have another question from Corinne. How is it? Well, this is a really important one. How is it for the patient? Well, they're all important, but this one speaks to what we were chatting about earlier. How easy is it for the patients and the therapist to set up the system and to start the system, to adjust the therapy settings and ensure that the training is carried out according to the therapy goals? So it's about that. How do we implement it and ensure the fidelity of the system when we're using it?
Yeah, that's a lot. We've done a lot of work, like from the very start of our, European trial, we had really simple things like logging into the device was really a pain for patients, and it turned out that wasn't very secure because they would put the password on a sticky note and stick it on the fridge, and yeah, it wasn't ideal. So things like that, we've removed the entire login system, and it's all remotely done by the therapist. So they securely log them in. There's no need for the therapist to put the patient to put in a username or password into the system. And then with the mobile app as well, we've built that into the mobile app. So the patients are sitting at home and if their smartphone beside them, they can log directly into the VR just by using the smartphone. So things like that makes it so much easier. And then we follow a lot of the user experience design principles around making it less clicks the better to get the things. So there's a lot of that has been embedded into our system, and that was before we even started eXRt. We had designed this platform that wasn't there in a sense, but now we've moved on from that now, and we've now been able to see it come into that physical space. But a lot of the patients, a lot of the therapists don't really see a lot of usability issues, and that's probably highlighted in the usability feedback that we're getting in the research.
And again, in our own study, the scale up, the big Interact funded study, in developing our platform, we spent a lot of time with patients and therapists, asking them, what do you want? How do you need it? How to design it? All and doing all that preliminary, which I'm sure you did as well.
Yeah, you can see in like the first or third slide, or third or fourth slide, we go out to a lot of the stroke groups and we get them to use it, and we tell them what's bad and what's good about it. And then that's what informs our design going forward. And then we do the same with therapists. We like, well, tell us what's bad so we can improve it. And it's an iterative process always, because you've a system that's very new. You're looking at a complex condition. So we want to make it as usable, and also, so we can get that access. Like I talk that, you're probably sick of hearing the word access, but that's what it's all about. Can we get it to them faster, but can they actually use it as quick as possible whenever they have it?
Absolutely. And the technology in itself can be intimidating for people that aren't used to it, like for therapists and so on that are not used to the technology. But it is, and we've developed videos and so on and so forth. And once people get used to it, and maybe speaks to the questioner, once people get used to it, it becomes second nature. And that's what you want to, that's what you want to get to. I have a question here about the financing of it. Could you elaborate on how the product is financed? I take it that's from research funding, etc. Is it covered by public health insurance for use, or is it privately paid? And that's about the accessibility for patients and long-term sustainability. So what's the funding model?
Yeah, so right now we're primarily B2B. So we're looking at hospitals, NHS trusts, for example, private healthcare. We don't right now we don't do it directly to patients at this stage. That's our ambition, that we want to do that. But right now we're just the theory behind that is if we can get the trusts on board, for example, or the hospitals on board, we can train them up, that the patients then can be trained, and then they're discharged and they can use it outside. So the whole idea is that hopefully we can train the therapist to train the patients to use it then outside.
Absolutely. And it's that blended care again coming through. It's so important. Thank you for that. Is it possible to share the references to the research projects? And I'd say yes to that. And I'll just mention that the webinar will be available on the eXRt for Rehab website. And Dominic, if you have any additional references you want to send through, we'll put those up as well.
That's perfect.
And again, mention about the competency level of therapists, when that drops off after a year. And again, that's about that's implementation processes. That's about revisiting.
Yeah.
5 trusts in Northern Ireland have been receptive to. What about the wider physio community? So what about the adoption from the wider physio community in the north? Has there been much of that?
Well, I think the likes of the Stroke Association partnering with us emphasises the fact that there's a big support network there. We go out on a regular basis to the Stroke Association support groups. They're all very happy to use it, and some have even asked us how much does it cost now to buy, but we just can't offer that service at that point. But I see a lot of support, and there's quite a few in the south of Ireland as well who have supported us. So I think it's there and it's still growing.
Okay, super. And another question from my colleague Trish, really interested in how the device can be personalized, in particular about grasp release in upper limb. It's extremely difficult. Can the device help with this, or can the apps help with this?
So in terms of grasp and release, yeah, I don't know if I can talk about this either. Yeah. So the intelligent system around that. So if patients can grasp only a certain degree, the system actually picks that up, and then after 2 or 3 repetitions of them detecting that, it will allow them to grasp at that degree. But also, we just can't let them sit there at that degree of movement, essentially, because you want to challenge them. You don't want to fall into a stage of plateau. So we want to challenge them. So we'll push them that wee bit extra, whether that's a millimeter or 2, or degrees of 2 or 2. We'll try and push them to challenge and exercise that range of motion.
Okay.
The other challenge is, yes, from grasp. You can grasp, but some patients can't release. That is a challenge. We have new future research now that we're working on to actually develop things like that. And so I hope that I can share it very soon, but I can't share that part.
Okay.
Unfortunately.
Okay. Super. Thank you. Thank you. I understand. And Jonathan asks, are you going to expand the technology into other conditions in addition to stroke? Obviously, many other conditions would benefit from something like this.
Yeah, and we definitely are planning to do that. And the first sort of obvious one for us is the brain injury, considering the sort of, you're seeing similar sort of exercises and rehab programs, and even in future pediatrics and orthopedics as well, around the hand measuring and movement. So there's definitely other conditions that we want to explore.
Absolutely, and I know some colleagues are working in Parkinson's disease and MS and so on and so forth. Thank you for that. Let me see. Do you use tracker sensor? Do you use tracker sensor? Is that a specific one? Tracker sensor?
Never heard of it. Is it physical tracking sensors? Maybe you're talking about or wearables?
It might be. Yeah.
No,
yeah, it must be.
We try to avoid them where we can, just because it leads to just more fitting to the patient. If you have having to put wearables, it becomes less accessible for the patient. They have to buy those, or for the hospital to buy those plus a VR headset, and then try to fit them on the patient. It's just a bit more cumbersome. Where necessary, we will probably end up using it if we look at other things like lower limb rehab. But we're hoping with our new developments in the long term, we'll be able to do the lower limb rehab without trackers, for example.
Okay, thanks for that. And we've another question around funding. How's the system funding? I think you've answered that. And the cost of the service user, and again, that's business to business, as you've said. You're hoping to branch into patient engagement directly, but not yet. Thanks. Can the sensor track lower limb? You've sort of answered that. Can the sensors track lower limb movements as well as the upper limb? I think you're moving in there.
Yeah, it can. Yeah, but we're moving in there.
Okay, so colleagues, I think that's all the questions, unless I missed anybody. I'm really, really grateful for your time again, Dominic. I think it was really interesting. An awful lot of overlap with our own work, and an awful lot of learning. And I hope we'll be able to continue to partner up. And I hope that the colleagues that are online will engage with the next webinar that should be coming up in a month or so. But really great stuff. Super. I'm delighted to see it. And we will talk again.